Welcome to part 2 of this 2-part episode on genetics. I'm so glad to have you back. In our last episode, we talked to Dr. Millie Sikor, who's a triple board certified fertility specialist and also genetic counselor, about so many of the things that you really should know about your genetics and about genetic screening. Very often, we think about genetic screening like the direct to consumer testing or other things that may be popular and may be interesting to you, but there's so much more to know and so many things that are essential to address if we're thinking about having children. There's so many issues that we may have, or maybe we don't know we have, and we're passing on to our future children. So, in this episode, we're going to dig further into some of the genetic tests and why you need to know about them. We're going to talk about donor conception and what sorts of tests your donor should have, and how to understand what you need to know and how to arm yourself with the information so that you can talk to your doctor and advocate for yourself, because ultimately you are your best advocate. So tune in. I think this is going to be a fantastic series for you. Take notes, rewatch it. I think you're going to love it. From our Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. As the leading destination for support and education for people using reproductive medicine to grow their families, we cut through the noise to provide you with research-based information, effective and actionable strategies, and the support that you need to feel better so you can get into the driver's seat of your life and build the family of your dreams. We look forward to seeing you inside. The screening is a little bit different. We were talking in the last episode about PGT and PGT-M, and maybe you can review that a little bit for our audience who didn't hear that last episode, but you should listen to it, and help people understand, well, if I'm in one of these three categories, what do I do? What's next?
Yeah. So let's talk about the group that is like your typical couple, and they are just trying to have a baby and no family history, no personal history. So when they usually come to either their primary care provider, OBGYN, and also their fertility specialist, they should have a comprehensive family history taken, because sometimes there, when we sit down with a couple and we start to tease out the details of their family, we go 3 generations and we find out, like, is there anything different about your brothers and sisters, about your parents, and then their parents, and cousins and stuff. We find out that there is an actual risk. They just hadn't thought about it, or it wasn't brought up. So the first step is, whenever you're thinking of family building, it's important to consider family history, and it should be done by a professional who's available, is able to interact that information. Once you have the family history and we didn't find any other risk factors, then they should consider doing a preconception carrier screening. So let me tell you about that test. Very simple test. It is a saliva sample, or it can be a blood draw, which is done for a panel of genes. Some of the doctors, mostly primary care providers or OBGYNs, use smaller panels, between, like, I would say, less than 100 genes in there. Some doctors will do 4 genes or 14 genes or less than 100 genes. But in fertility clinics, we are mostly using panels that range between 200 to about 700 disorders. So what this test does is, in that book analogy, this test is going into about those 200 to 700 different chapters and reading both the copies of those chapters and finding out if there is any kind of word that's different. The technology that's being used is called next-gen sequencing, and that helps with, like, reading the whole chapter word to word, comparing it to what it should be, and then saying, yes, there is a change or a mutation. And that test result comes back in about 2 to 3 weeks. So easy test to do. It's done through blood or saliva. You can get the blood drawn at the fertility clinic, or the kit can be delivered to home. And then you can do the swab, send it back to the testing lab. In 3 or 4 weeks, we'll find out if you're a carrier of any of these genetic conditions. The partner can do the testing at the same time if you want, like both partners can do it at the same time, or the partner can get tested once we find out what the first partner is a carrier for. I get this question all the time, so I'm going to address it here. One of this is my insurance cover this test? Right. So most of the time, the insurance information is sent with the test, and then most of these testing labs will actually give an estimate to the patient after running their insurance of what the cost looks like. Sometimes the test is completely covered and there is no additional cost. Other times there can be some cost based on your deductible and your plan. If the patient just wants to go through a self-pay system, usually this test is like less than $400 for most labs for the test. So if I talk to somebody who has a child with a genetic condition, it's a no-brainer to get the test, whether or not it's covered by insurance or not, because the information that you get from the test is so important to know before conceiving. It's life-changing. And then if you have a child who has a rare genetic condition, and I have a very close friend who has a child with a rare condition, and I'm very close to the rare disease community. It's millions of dollars that go into taking care of that child, hours and hours of parents' time and work, and then you have a child that you see suffering in front of you. So carrier screening, the test is easily done, easily interpreted most of the time, and there are resources available for it. So I think for all couples, low risk couples that don't have anything else going on, carrier screening is a big test to do. The chance that a couple is a carrier couple will depend on, what kind of ethnic background they are from. But usually we quote 1 in 50 individuals will match up for a genetic condition that can be of significance for
it's a lot.
So it's important to know that. I think then all the reproductive options become available to that couple. What I mean by that is, if we've picked up that an individual is a carrier of a condition, first of all, we can find out that there is no personal risk to them. There are a few conditions on the carrier screening that do have some risk to the individual who's carrying those conditions themselves. So you can make changes based on that. A good example is a carrier of a sickle cell anemia. They don't have the full sickle cell disease that involves pain crisis and, problems with organs and stroke and other things. They don't have that full disease, but they can be at risk of sickling episodes in their blood when they go to high altitude or get dehydrated or get sick. So individuals can find out their personal risk, and then they can find out their reproductive risk. And then they can choose to still get pregnant naturally if they wanted to, with or without prenatal testing, depending on the condition and how they feel about that. They can not test during pregnancy if they wanted to, go the regular way, but at least alert the pediatrician when the baby is born that we are both carriers of this condition. So the doctors are ready. Some of these conditions require newborns to be on a special formula, and they can actually be ready with the formula and everything.
Yes.
The second option is to do something called PGT-M, which is pre-implantation genetic testing for a monogenic condition, where the fertility doctors can help build a test to test the embryos for those two mutations of an autosomal recessive condition coming together to find out which one of the embryos is affected, which one is a carrier and typical, and then you only transfer the embryos that are unaffected from the disease. So you are bypassing that risk of 1 in 4 affected. And that's done with IVF. It is not available for somebody who's doing a natural conception. It's available for somebody who's ready to do in vitro fertilization, where the eggs come out, eggs are fertilized, they grow to a blastocyst stage, that stage that I was telling on day 5, day 6. At that point, the cells that are going to make the future baby, called the inner cell mass, make a clump on one side of the embryo. And the rest of the cells kind of line up in a spherical shape called the trophectoderm. They're going to make the future placenta. So we can take 4 or 5 cells out of that outer shell and send those cells for testing. If a test has already been built for that family, then those cells can be tested for that condition and find out whether the embryo is affected or not. And the embryo is frozen for a future use. The embryo can't wait for 2-3 weeks outside the body, right? So it's going to be frozen at that day 5 days 6 blastocyst stage for a future use. Every embryo, whether it's affected or unaffected or carrier, is going to be frozen. We don't know the results of any of those embryos. So embryos are all safe, and then they are numbered and they are stored properly. And then we get test results back. So then we know embryo number 1 is okay for the condition that we were looking for, versus embryo number 2 has the condition and is at a high risk for health challenges or intellectual disability or birth defects. And then we don't transfer that embryo. We preferably transfer the embryo that got the combination of the genes that are not going to cause disease.
Not affected.
Yeah, unaffected.
Yeah.
And in that way, there are some couples that will use the carrier screening information to actually change their reproductive options to not use their own biological egg and sperm. One partner can, choose to use donor sperm or donor egg, depending on what kind of disease is it. Some people might choose to add a child to their family by just adoption or foster parenting instead of having biological children based on the risk. And then there are some individuals that will decide not to have children based on that. So if you knew your carrier status and the carrier status of your partner or the egg or sperm source, you now have the full range of options that are available to you. You can choose to, conceive naturally and alert the pediatrician and all of that. That is the carrier screening and the PGT-M for that kind of situation. For the 2 other groups that I talked about, where there is inherited cancer risk or there is a risk of a genetic change that is being passed on from a parent to our current couple that is in front of us or individual who's in front of us, they can also, once we know the mutation, the genetic change that they have, embryos can be tested by that same process called PGT-M. So from your last episode, when we are talking about PGT is this terminology that we use for testing of IVF embryos. And it basically, one group of it is the PGT-M, where the monogenic condition or the single gene or multiple different genes that cause disease are being looked at. The second type of PGT is called PGT-A, which is the aneuploidy. Aneuploidy means, like I was saying, an extra or a missing book. So PGT-A is available to all couples who are trying to do IVF if they wanted to, mostly shown to be beneficial for those who are older in their age group, especially if the woman or the egg source is older. Then, there is a high risk of age-related aneuploidy being a reason. That brings us to the age factor, as you were mentioning. For all of us, and this is not new information. I'm sure your audience already knows about it.
Well, only a little bit, just only a little bit. Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short-term, but long-term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor-conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. I just want to say one thing, just to backtrack for one moment, Dr. Thakur, because you're giving us so much great information, but I just wanted to mention, because people do write in about concerns about testing. And, 30 years ago, when I started in this industry, the process of testing was much more invasive. We had embryos that were not blastocysts yet, and now it's much safer. So all of you out there don't have to worry in the same way. And also, I think it's really, really important to understand that these difficulties are things that you can potentially prevent. But it doesn't mean it's perfect. And
Yeah.
so, even though there are all of these wonderful tests, and yes, hundreds of tests, I very often see people who say, well, my embryo was tested, and therefore I'm going to have a baby. And that is all of a sudden is going to be 100%. Now, apart from, the process of implantation, which is kind of a black box for all of us, right? Also, within the embryo, there's only so much we know, right? We know more all the time, and the tests have expanded over the years, but it's not perfect. So, even if there are hundreds of difficulties we can test for, there may be others that we just don't know about yet, right?
Yeah, and I think that's an important point that you bring, Lisa, is that when we are looking at genetic testing, I want all of the audience to kind of take home this message. The word genetic testing comes in all different spectrum of testing. A genetic test could mean that we are looking at the number of chromosomes, either in an embryo or an adult or a child, right? Which is counting the number of books. That test does not look at the page level. It does not look at the word level. It does not look at the methylation level. It's not looking at the bookmarks. That test is called a chromosomal analysis, and it's only looking at the number of chromosomes. If it's done in an adult or a child, that chromosomal analysis is done through something called karyotyping or karyotype, which is making this beautiful picture of like the chromosomes and making sure that all of them are there. That test is very, very specific. Like you will get 99.9% good results from that test. It picks up what it's supposed to pick up. But in an embryo, when we do that same test, because embryos are small, they're smaller than the tip of the hair. So the cells that we are taking out is 4 or 5 only cells, and we are taking it out from the outer shell of the embryo. We are limited in what we can test for in that PGT-A testing. So the technology is different than what it would be for a child. So next gen sequencing is the cornerstone of PGT-A testing. And in that case, the efficacy or the accuracy of the test is quoted to be about 98%. That means if the test says that the embryo is euploid, or the test euploid means all 46 chromosomes are there and the gender chromosomes, you can tell them, versus an aneuploid, with extra or missing chromosome, those test results are always very clear. Most of the time, they will match up with the inner cell mass or the baby portion of the test. But then there are test results that are other shades of that PGT-A testing. It's not so
Yes.
binary anymore.
Yes.
And mosaic test results,
Yes.
segmental test results. And these are technical things that we can discuss in another episode. But basically, those kind of test results have more inaccuracy about them. The embryo could do just fine if it's a low level mosaic embryo, but it's a category of its own in a test result. So
Mm-hmm.
coming back to like the level of testing. So one test is for adult or child, the karyotype, or for PGT-A for an embryo. The second type of test is called a chromosomal microarray, which counts the pages of the book. It's looking for deletions and duplications. That test is not usually looking for word level changes. Can pick up sometimes some genes that have gone missing, but it doesn't like look at the actual words. And the term is still used genetic testing.
Mm-hmm.
The same thing is for the third level of test, which is looking at the words or mutations. So the genetic panels, either the carrier screening panels or the panels that I was saying when there is a parent who has like inherited cancer risk, right? Then you
Mm-hmm.
want to test yourself for cancer related gene, and they're looking at the words of those genes. So genes like BRCA1 and 2 are looked at
Yes.
and read. Every word is read in that chapter to make sure that there is no mutation, right? And
Mm-hmm.
then the fourth level of test is a methylation test, done a whole different way, read a whole different scenario. So sometimes families will come to us and they'll say, oh, I've had genetic testing before
Mm-hmm.
and I'm not at a risk. So when we get that kind of information, we delve a little bit deeper to see what test was it done. I want to see the test report. I want to see if it was done through a medical grade lab. Did it cover the enough genes in there versus only 4 genes were looked at? They didn't even go to the 6th chapter, which is the one that could be at risk in that family. They only looked at 4
Yes.
chapters, right?
So
So we have
important.
to see how big of a panel it was. Did it cover enough risk? Was the depth of the coverage really good? Like, did they do a good job of reading it? And then the last thing that I want to point out in this whole situation is sometimes families are falsely reassured because they had direct to consumer testing.
Yes.
So I want to
Yes.
like kind of and have them understand, have everybody understand that direct to consumer testing is developed to screen out some conditions, but it's not reading the whole chapter many times. So like if somebody tested negative for cystic fibrosis, which is the chapter for that, or the gene for that is the CFTR gene, they are mostly doing genotyping. They're going into some important sentences on a page and saying, are the words okay on that sentence? So they're not
Mm-hmm.
reading the whole gene from top to bottom in a medical grade lab. And a negative test result there is a good test result. That means at least you don't have the big typos in there that usually everybody could have. But it doesn't take away the risk or reduce the risk to a point where I can feel reassured that this couple's risk of having a baby with cystic fibrosis is reduced to the point as best as we can reduce it. So families should always keep genetic test records in their phone nowadays or in a paper chart. Make sure that you have a copy of what was tested for, what am
Yes.
I negative for, and whether or not it was a medical grade test versus it was like lumped into a package where some people feel really great about some test and it's like really looking at your ancestry.
Right.
Like
It's not enough.
it's not
Not
even looking
enough.
at the gene level. Yeah. So I
Yes.
think it's important to know those nuances. So from coming back to the point of PGT, we talked about PGT-M where you're looking at the rare diseases. We talked about PGT-A where looking at the chromosomes in an embryo to make sure that they get screened and those that have extra or missing chromosomes are not transferred as a preferred embryo. The third type of PGT testing is called PGT-SR, which is structural rearrangement. There are some individuals that have balanced translocations or something called Robertsonian translocations, inversions. Those are conditions where all the chapters are there, all the pages are there, but some of the pages of one book have switched places with another one. So that individual has all of the information that they would need for living a healthy life. But when they're passing on that genetic information, passing on those chromosomes, there could be extra missing pages because at one time an individual only passes one of their 2 chromosome copies.
Mm.
So PGT-SR is a test that's specially designed to pick up unbalanced information from a chromosome level being passed on to a baby. So this is applicable to individuals who have recurrent pregnancy loss because of an inherited cause.
Mm-hmm.
So there is a whole another workup that we do for individuals who have gone through 2 or more consecutive clinical losses, right? If you have 2 or more losses, that's very unusual. One loss is okay, it happens, and about everybody would have about 10 to 15% risk of having a loss during their life if they're going to be getting pregnant. But individuals who have 2 or more losses, if somebody has like 3 or 4 losses, that's not usual.
Mm-hmm.
Most of the time it happens because of multiple different reasons. Most of the time it's like the parents are okay, but the chromosomes that are being passed on, an extra or a missing one passes through at the time of conception. That's your age related aneuploidy causing miscarriages. Older women and older fathers can
Mm-hmm.
have a higher risk of miscarriage because they are all right, but their egg and sperm are bringing an extra or a missing chromosome, or a segment of a chromosome causes losses. But then there are individuals who would have an inherited genetic cause where they don't know that they have it, but they have a translocation. Some books have
Yes.
changed pages, and then when they're passing that information, they would have repeated miscarriages. They are also they can have a normal pregnancy. I have a few families where the first child was normal because balance
Yes.
information was passed to them. then their second and the third pregnancies ended up in a loss because now the unbalanced information is being passed on. So for those families, we have PGT-SR. And the
Yes.
last type of PGT is PGT-HLA. There are some families with rare genetic conditions, mostly blood-related conditions like sickle cell disease or Diamond-Blackfan syndrome, where they have an affected child already. They are at high risk of having another child with the same condition, right? Sickle cell is 1 in 4 risk, or Diamond-Blackfan syndrome is a very high risk of a next pregnancy to be having that condition. And their child, the current child that they have, requires a donor
Mm-hmm.
for their
Mm-hmm.
bone marrow transplantation. So HLA can be also used to match siblings for an HLA match. HLA is used during that transplantation of the bone marrow. So to summarize everything that we have talked today, one is to recognize which group of individuals you belong to. Are you the typical individual or couple that doesn't have a personal history, doesn't have anything in their family? And that answer is going to come from talking to your family. So this Thanksgiving, when you get together
Mm-hmm.
and if you're thinking of having a baby in
Yes.
the next year or two, just find out, what did aunt this and this have? What did grandma have? What is the history? So figure out if there is any red flags that are there. Then you see if you already have a typical kind of risk, then go for carrier screening, go for discussion of pre-implantation genetic testing for aneuploidy. The doctors will guide them if you're a good candidate for either one of those tests.
Mm-hmm.
The second group, where you know that something runs in my family but you don't know if it's affected you go for testing, ask your doctors, and do some sort of genetic testing for it. And then if there is a long history, you personally are also affected in all of those scenarios, when there is a high reproductive risk, then consider either natural conception with or without testing during pregnancy, IVF
Yes.
with pre-implantation genetic testing, or other options to build the family.
Yes. So, what I'm really interested in also, Dr. Thakor, is a couple of things. First of all, I think that this is incredibly valuable information for everyone. But what you just said about second child. So, for example, I worked with a woman who her first child was healthy and the second one had Fragile X. So, I think, yes, it's helpful to think about these things during Thanksgiving dinner if you're planning your first child, but even if you're planning your second child, it's helpful to think about these things, right? And then the second point is, and I think a lot of our audience is going to be very curious about this. What about their donors, their sperm or egg donors? Are they sufficiently tested?
Yeah, so if family building involves an egg or sperm donor, then for sure the individual that is seeking a donor should get a good panel for carrier screening. They should know what they are a carrier for. And then when they are selecting a donor, in addition to looking at their family history for the donor and other risk factors in the donor, they should also be matching the carrier screening test results for the gene that they are positive for, to make sure that the donor is not the carrier of that particular condition. Also, as you mentioned, Fragile X, these carrier screening tests mostly will have some X-linked conditions. X-linked conditions are conditions that are on the X chromosome. Because women have two X chromosomes, they can be carriers of the condition but not manifest the disease. Fragile X is like that. So when you are going to be looking at that information, you also have to look at that Fragile X or other X-linked conditions that these tests can pick up. And then the inheritance of that is different. You pass on the mutation. If a woman is a carrier of an X-linked condition, she passes it on to half of her boys and half of her girls, because boys don't have a backup copy of their X chromosome. They have an X and a Y, and Y has different genes written on it. Boys will usually manifest it in a very severe way
Yes.
most of the time. And then girls can, be carriers. Most girls will be carriers of the condition that are X linked, and they can pass it on to their boys in the future. So coming back to the point of when you're doing the disease or the risk assessment, you have to put all of those factors into play. And that's why,
Mhm.
there can be healthy children in the family, but then you can they then blindsided with a affected child later on. So having that conversation is important.
So important. And I think just to kind of underscore that, it's important also, I think, for everybody to think about this beyond recessive carrier screening, right? Because just kind of go back to the way we started, there's some things we have control over and some things we don't have control over, right? And so people very often want a donor that looks like them or has their musical talent or any of these things. But being able to screen for inherited difficulties is something that they can do. And something else they can do is, as you mentioned, look at the family history, right? Because a donor is not going to fail screening if his grandfather died of cancer. I mean, that's kind of a normal way to die, right? But if you have the same type of cancer in your family, maybe it's not the best match for you.
Yeah. And the banks actually will provide that information to the individual who's seeking a donor. There are so many different options that are available in terms of sperm banks and egg banks. And I think one of the things that every individual seeking a donor should be doing is to be able to look at that information yourself. So, like you mentioned, a lot of focus or control for that individual seeking a donor comes from the fact that they're trying to match some attributes, which is a great thing. We want them to be able to do it, to be able to participate in the process. But just because we are using a donor, the stringency of that genetic process doesn't change. So, what that means is the egg and the sperm bank should be able to assist in providing a good history from the family. And if there are red flags that you are seeing, it's good to question that with the bank. And these banks will provide genetic professionals. Mostly there will be a genetic counselor that can answer the question, and they can also help you understand, what kind of risk it brings together with your family history.
Yes.
Most of the time, individuals are so overwhelmed by that process that they will say, oh, this is fine, this is fine, this is fine, I just want to have a baby, right? But I
And
think
donors are
it's
healthy, right? They're going to be
eh,
healthy.
they assume that donors are going to be healthy,
Yes.
but there are levels of testing that we can do for a donor, and it's good to have the maximum level of testing that you can get from that particular donor bank.
Yes.
It would be good that the bank follows the guidelines. Like American Society of Reproductive Medicine has published a document that tells us about, the professionals who work in the field, about how to take care of different types of family history. There are diseases that are a complete no-no to be taken as a donor, right? And
Hmm.
there are other things where you can consider them on a case-to-case basis. And then there are other conditions that we can't screen for. Like some conditions are just multifactorial. Like there is a lot
Yes.
of diabetes in the donor's family. Like, how do you take decisions for that? And that's why there are medical professionals that are available. Like, I'm always happy to see that all of these banks are coming up to standard with genetic professionals for families to answer their questions. The caveat to that is the onus of healthcare in our whole system here in the US or abroad, everywhere lies on the individual.
Yes.
If you do not
100%.
know, if you do not know, are not even aware, it's not even in your radar that there could be a condition that I could be carrying, you could match up with a donor, even with the best intentions from the bank, but you just didn't choose to sign a check mark and you waived your right to do the genetic testing,
And you
then
didn't know.
you didn't know. And you're thinking into going into that everybody, all my friends who've used donor have done all right. You're comparing yourself to the general population, but you're not comparing the results of the donor compared to you. And each one of us is
Yes.
unique. Each one of us is going to be different. There is nobody genetically similar to you, not even an identical twin, right? So it's
Yes.
like, to take all of the information from a medical source and then carving out the family building that you desire with all the emotional nuances and all of the attributes that we want. Of course, we want all of that, but we also want as less of a residual risk to a baby when we have a choice.
Yes, yes, absolutely. I wish I could put this piece on repeat over and over and over again, Dr. Thakur, because this is so, I hope everyone's writing this down. This is so important for your health and for your future family. So
Yeah.
thank you so much for this. This has been so wonderful and so jam-packed that I hope everyone rewatches it and certainly takes notes. And how can people reach you, Dr. Thakur?
So I founded a practice. It's called Genome Ally. We are a telemedicine reproductive genetics practice. We take care of like individuals who are either being proactive, typical low risk couples wanting to do carrier screening. We also take care of individuals who have a personal or family history of a disease, finding out the mutation for them. We work with fertility doctors and partner with them for patients who are going to be doing IVF with PGT, PGT-A results, or PGT-M or PGT-SR. So you can look us up at www.genomeally.com. Our number
Great.
is 616-676-6879, and we are waiting to talk to you if you have a genetic risk or want to explore what genetic risks you should be taking care of, or if you want a good 3-generation family history done.
Yes. And as you just said, Dr. Thu, I'm just going to repeat this for everyone out there. This is so important to remember. Just because your friend did something doesn't mean it's going to work for you. Just because you feel like there's no family history of something doesn't mean that it's not in your body. And so we just don't know until we ask the experts. And I think that you've really explained that so beautifully today, Dr. Thakur. So thank you so
Thank
much
you.
for your time. And thank you for coming. And thank you, everybody, for listening, because this is really valuable information for you and your future family. If you haven't subscribed yet, we know that there are a lot of people out there who listen to this podcast and love it, but haven't subscribed. So if you haven't, please just press the subscribe button. It will help us a lot. And I look forward to seeing you next week.
Thank you for having me.
Thank you for joining me today. I hope this was helpful to you. And if you'd like more personalized support, more information, and more education, you can find it in the show notes under the Building Your Family community. We'd love to see you inside. And if you were interested in today's topic, you will really like this video.